Welcome, everyone. This is Mini Talk 1 in our Veterinary Toxicology series, Principles of Toxicology, the Big Picture. Over the next 15 minutes, we're going to build a mental framework for how toxicology actually works. Not a list of poisons to memorize, a way of thinking that you can apply to any toxic exposure you encounter in practice. The key insight we want to walk away with today: poisons aren't magic. They follow rules, and once you understand those rules, you're already most of the way to figuring out what to do about them. Let's start with the foundational idea. Paracelsus, a 16th century physician and alchemist, gave us the most important sentence in all of toxicology: the dose makes the poison. What that means in practice: there is no such thing as a universally safe or universally dangerous substance. It's all about dose. Water, drink too much and you get hyponatremia. You can die. Botulinum toxin, one of the most lethal substances known, is used in medicine every day at tiny doses. So as clinicians, our job isn't just to identify the toxin. We need to think about dose, route of exposure, and critically, which species we're dealing with, because a dose that's fine for a dog might kill a cat. We'll come back to that. The dose-response curve on this slide shows a classic sigmoidal relationship. At low doses, no effect. As dose increases, you start to see responses. The ED50 is the dose that produces an effect in 50% of individuals. This concept underpins everything we do. One of the most practically important concepts in veterinary toxicology. Species differences are enormous, and they matter clinically every single day. Let's walk through the table. Cats. Cats lack a functional glucuronidase transferase enzyme. This is a key phase 2 liver enzyme that conjugates many drugs and toxins for excretion. The result: cats can't detoxify acetaminophen, Tylenol. What's a headache remedy for a human is a life-threatening emergency in a cat. We see methemoglobinemia, Heinz body anemia, and liver failure. Dogs are curious and will eat almost anything. Xylitol, a sweetener found in sugar-free gum, peanut butter, and baked goods, causes a massive insulin release in dogs, leading to profound hypoglycemia. Cats appear to be less sensitive. This is an exposure almost entirely unique to dogs because of their eating behavior. Horses. The hindgut is central to equine health. Ionophores, antibiotics used in cattle feed, disrupt cellular energy in horses and cause cardiac and skeletal muscle necrosis. Horses are extraordinarily sensitive. What's therapeutic in cattle is fatal in horses. Birds. Birds have a unique respiratory system with air sacs that allow one-way airflow. Incredibly efficient for gas exchange, but also incredibly efficient at absorbing airborne toxins. Overheated nonstick Teflon pans release PTFE fumes that kill pet birds within minutes. Cattle. Rumen microflora are the engine of cattle metabolism. Anything that disrupts the rumen, including high non-protein nitrogen loads like urea, can lead to excessive ammonia production and systemic ammonia toxicosis. The takeaway: never assume, always species check. Let's talk about how toxins get into the body and why the route matters as much as the substance. Oral ingestion is far and away the most common route in companion animals. Dogs eat things they shouldn't. Cats groom themselves and ingest whatever is on their coat. When something is swallowed, it enters the GI tract, gets absorbed into portal circulation, and has to pass through the liver before reaching systemic circulation. This first-pass metabolism can significantly reduce how much toxin reaches the rest of the body, or in some cases, it activates a protoxin into its toxic form. Dermal exposure is critical in cats. If you put an organophosphate-based insecticide on a cat's skin, they will lick it off. Dermal exposure becomes oral exposure through grooming. Also, remember that some toxins, especially lipophilic ones, absorb readily through skin even without grooming. Inhalation is fast. There's no first pass effect. The toxin goes straight from the lungs into systemic circulation. This is why certain gas exposures can cause near instantaneous collapse. The bar chart on the right shows approximate onset times by route. IV is essentially immediate. Inhalation, minutes. Oral, typically 30 to 60 minutes, depending on stomach contents. Dermal, slowest. But don't let that fool you. Dermal toxicosis can be severe. Understanding the route helps you predict the timeline. How fast will this patient deteriorate? Have they already absorbed most of the dose, or is there still time to decontaminate? Framework I want you to carry with you, the toxicology triad. Clinical outcome in any toxic exposure is determined by three interacting factors: the toxin, the host, and the environment. Let's talk about the host, because this is where clinical judgment really comes in. The same dose of the same toxin can produce dramatically different outcomes depending on who the patient is. Age, neonates and very young animals often have immature liver enzyme systems, so they metabolize toxins more slowly and are generally more vulnerable. Old animals may have reduced kidney or liver function for the same reason. Pre-existing disease. A dog with hepatic insufficiency has reduced first-pass metabolism and reduced capacity for phase 1 and phase 2 biotransformation. A nephropathic patient can't clear renally excreted toxins efficiently. Genetic mutations. This is a real world example. The MDR1 gene mutation, now called ABCB1, this mutation affects P-glycoprotein, a drug efflux pump in the blood-brain barrier. Collies and other herding breeds commonly carry this mutation, which means ivermectin, normally safe, crosses the blood-brain barrier and causes neurological toxicity. A dose that's fine in a Labrador can be fatal in a collie. Nutritional status. Selenium deficiency alters antioxidant capacity. Protein malnutrition reduces the substrate available for conjugation reactions. Co-exposures. A patient on a drug that competes for the same metabolic enzyme may have dramatically altered toxin kinetics. So the question isn't just what did this animal eat? It's who is this animal and what makes them unique. Understanding the mechanism of toxicity is what connects the toxin to the clinical signs you'll see and to the treatment you'll choose. Let's run through the major categories. Receptor binding. Many toxins work by hijacking normal receptor signaling. Organophosphate insecticides irreversibly bind acetylcholinesterase, the enzyme that breaks down acetylcholine. The result? Acetylcholine accumulates at synapses. You get the full cholinergic storm. Salivation, lacrimation, urination, defecation, GI distress, emesis, plus muscle tremors, and, in severe cases, respiratory failure. Treatment? Atropine to block muscarinic receptors, plus pralidoxime if given early to regenerate ACHE. Oxidative stress. Some toxins or their metabolites are powerfully oxidizing. They oxidize the iron in hemoglobin from Fe2 plus to Fe3 plus, creating methemoglobin, which can't carry oxygen. Cats are especially vulnerable due to their limited antioxidant defenses. Onions can cause Heinz body formation in dogs, mitochondrial dysfunction. Cyanide from cherry pits, for example, blocks cytochrome C oxidase, shutting down the electron transport chain. The cell can't make ATP. Tissues die. This is a histotoxic hypoxia. Blood oxygen is normal, but cells can't use it. Ion channel disruption. Pyrethrins keep sodium channels open, causing repetitive neuronal firing. Cardiac glycosides, like digitalis and certain plants, foxglove oleander, disrupt sodium potassium ATPase in cardiac muscle cells, causing arrhythmias. Direct cellular injury. Caustics physically destroy tissue. Heavy metals denature proteins and disrupt enzymatic function. The key insight: if you know the mechanism, you can predict the clinical signs, and often you can reason your way to a rational treatment, even for unfamiliar toxins. Take a moment and think through this case before moving to the answers. This is a real scenario that happens in practice. Owners see their dog has worms, or they're trying to save money, and they administer ivermectin-based cattle products. The labeling doesn't always warn clearly about breed-specific risks. The three questions target the core concepts from this talk. Question 1. What principle explains this? Answer: the toxicology triad. Same toxin, same dose, different host. The species and genetic background of the host determines outcome. A cattle dose is not a dog dose. Question 2. The MDR1 or ABCB1 gene mutation. This affects P glycoprotein, the efflux pump in the blood-brain barrier. In normal dogs, P glycoprotein pumps ivermectin out of the CNS before it accumulates. In MDR1 mutant dogs, which includes collies, Australian shepherds, shelties, and others, this pump is non-functional. Ivermectin crosses freely into the brain. Question 3. Ivermectin enhances GABA activity at GABA-gated chloride channels in invertebrate nervous systems. That's how it kills parasites. In mammals, GABA is normally excluded from the CNS by the blood-brain barrier. In MDR1 mutant dogs, ivermectin enters the brain, potentiates GABA signaling, and causes profound CNS depression, ataxia, obtundation, coma, and potentially respiratory depression. Treatment is largely supportive. No specific antidote. This is a case for IV lipid emulsion therapy in severe cases, which can sequester the lipophilic ivermectin. Supportive care, maintain airway fluids. The genetic test for MDR1 is commercially available. This is information that should ideally be in the medical record for all herding breeds. Here are the 5 big ideas from this talk that I want you to carry forward. 1. The dose makes the poison. Memorize this. Live by it. It reframes every exposure question. 2. Species differences matter enormously in clinical practice. Cats, dogs, horses, birds, cattle, they all process toxins differently. What's safe in one may be fatal in another. 3. Route determines timeline. Understanding how quickly a toxin is absorbed tells you how urgently you need to act. 4. Think in triads. The outcome of any toxic exposure reflects the interaction between the toxin, the patient, and the circumstances. Don't just ask what, ask who, how much, when, and by what route. 5. Mechanism is your friend. You don't need to memorize every toxin if you understand the mechanisms of harm. That knowledge lets you reason through unfamiliar situations. In Talk 2, we're going to go deeper into toxicokinetics, how the body handles toxins over time. We'll cover absorption, distribution, metabolism, and excretion in a way that makes clinical sense. See you there.